Okay, everybody on Zoom and in the chambers, good morning. We will call to order the October Board of Health meeting. For the record, there's a copy of the Open Meetings Act on the north wall of the legislative chambers. And with that, we will open with roll call.
Wade. Here. Festerson. Here. McNally. Rogers.
Here.
Weiss. Here. Jones. Wilkin. King. Espinoza.
We'll go to item 2, and that's approval of the minutes for the month of September. Is there a motion to approve?
So moved.
Motion by Wade, is there a second?
Second.
Second by Festerson. Roll call.
Okay. Let's see here. Wade.
Yes.
Rogers.
Yes.
Weiss. Yes. Espinoza. Festerson.
Yes.
Okay.
We'll go to items for approval, items.
Rogers.
Yes.
Jones. Espinoza. Weiss.
Yes.
Wade.
Yes.
We're going to presentations and item A, 15-year recognition.
Good morning.
Morning.
I am so excited this morning to get to recognize one of our employees for 15 years of service, Mr. Andy Wessel. Come on up, Andy. Andy is in our Health Equity and Planning Division, and Andy, I have to tell you, is one of these people who is down for whatever. He's extremely helpful. Anytime we have ever needed something and been like, hey, Andy, how does this sound? He's like, I'm on it. And he gets it done and does it with a smile. And I just so appreciate that spirit. And I also want to say that he really is one of our employees who fully embodies our values in terms of people first and belonging. I don't think anybody who's ever met Andy walks away from a meeting with him or a conversation with him without feeling like they are totally accepted and cared about. And honestly, while that conversation is happening, probably feels like they're the only person in the room because he is just so good at really listening and focusing on people. And I know that our communities that he has worked with very closely, especially during COVID, worked with the North Omaha Community Care Council, South Omaha Community Care Council, working with our refugee population. He does a ton of work, and it all, I can tell, comes from the heart. And we just so appreciate everything that he has done for Douglas County Health Department. So Andy, congratulations on making it through 15 years with us.
I will say the last 5 were a little bit harder than the first 10.
I can understand that. So I don't know if, we've got Jamin to take pictures today.
Oh, okay.
So, do you want us to come over here?
Shouldn't lie.
Oh, see so much for everything. Thank you, Dr. Yeah, you bet.
Andy, hold up. So I'm just curious, where did you start from to where you are now?
I
'Cause
was
I'm-
a temporary employee.
Go to Mike.
I started at the health department as a temporary employee during the H1N1 pandemic. So, gone through 2 pandemics with the health department. Really okay if I don't have to go through a third. So,
And before, who were you under before? I know you converted to equity, but I'm trying to figure where were you at when you started?
so
at Temple
temporary, I was under Carol
Okay.
Allensworth, but then spent a good stretch with Mary Bolliff, because then it was that $5.7 million CPPW grant, and then health impact assessment work, and then moving that into continuing stuff with transportation and housing, and then into the equity work.
Yeah, and then in there, I can recall there was the trip when you and Dr. Poor were on a trip to become, like, we would become the Chamber of Healthcare, the hotline.
Yeah, I oversaw the info line during COVID. The piece that you're referring to, the Kresge Emerging Leaders
Yeah.
in Public Health, Dr. Poor and I ended up getting to take part in that. And part of that was, how do we have this perspective of really being an advocate and coach for the health of our community? And some of that work is similar to what the Chamber of Commerce does,
Yeah.
in terms of they want us to be a thriving place to live, and their focus is on business climate. We want to be a thriving place to live. Our focus is on community health. And so the one piece that's a carryover from that work is the tagline that we have for the department, that healthy, vibrant, everyone, everywhere. That was our,
Yeah.
like, how do we get that role as succinct as possible?
No, I just wanted to note that because I think the timing came and you just happened to be the person, but your attendance kind of coincided with that real hard turn when we started driving social determinants of health
Sure.
outside of that. So I just want to recognize that. And thank you for your work.
Thank you all.
Hope you're here for 15 more.
Okay, appreciate it. That's
Alrighty.
the plan.
Okay, with that, item B and Caspers. Justin.
Good morning, everybody. I'm going to just take a second to introduce the CASPER, which is a community assessment for public health and emergency response. And Nebraska, and more specifically Douglas County, conducted its first CASPER after the Arbor Day tornadoes, which impacted Waterloo, Elkhorn, and Bennington. The health department partnered with UNMC's College of Public Health to assess the physical and mental health impacts on the community and to improve future emergency preparedness, including NOAA's post-tornado survey to enhance weather warnings. So a CASPER it was developed by the CDC. It's a rapid needs assessment tool that uses a 2-stage cluster sampling method, which these guys will get into more, to gather information on the individual household level. The primary goals of a CASPER is to initiate public health action and to inform emergency preparedness or emergency managers, identify information gaps, support disaster planning, response and recovery, and allocate resources effectively. And so with that, I'm going to turn it over to Dr. Christina Kent-Zinger. And Heather, can you pull up the presentation? Thanks.
Okay. So
We can answer questions afterwards.
I've already got it here. I believe it's this one, and let me share the screen. And minimize some of this stuff here.
That's all right.
And then just hang on. There we go. There we go. Okay, there you go. Okay,
Thank you for having us here today to talk about the results of this rapid needs assessment that we did. And so I'll give you a little bit of background about the methods that we decided to use, and then share some of the highlights of the results as well as the recommendations that we are making based on the results of this survey. So just to bring us back to that day, the Arbor Day tornado outbreak was the ones that we experienced here in Douglas County were part of a larger outbreak. The National Weather Service tracked 19 total tornadoes during that day. The combined total track length was over 200 miles. 5 of these tornadoes were EF3 or higher. The one that impacted Douglas and Washington County that day started at 3:50 and basically dissipated around 4:30 in the afternoon. So this one was interesting. It was a max width of 1 mile, which is fairly impressive. The track length was 31 miles, and they originally started off grading this as an EF3, but they have since upgraded it based on evidence to an EF4 with max wind speeds of 170 miles per hour. So fortunately, there were 0 deaths associated with this particular tornado, and there were minimal direct injuries associated with it as well. So Justin gave us an overview of the CASPER methodology. This is a rapid needs assessment, and the goal is to really get population level estimates so that we can really describe what the community has experienced either in a post-disaster setting, or it has been used in other settings like for community health needs assessments. The goal is to generate information quickly, to get in the field quickly, so it is a rapid assessment. You are mostly getting household level information, so you're asking questions that affect the whole household instead of individuals. And then you get these weighted population estimates, which are generalizable to the area, to the population that you are interested in. And we used a slightly different method than the traditional CASPER based on, do I need to do anything to the, that's okay.
Or no, it keeps trying to do stuff.
I didn't know if there was a problem. Okay, that's all right. So we did a slightly different method than the traditional CASPER based on some needs that we identified and some concerns about safety of teams going into the field in the immediate aftermath of the tornadoes. We ended up doing a stratified probability sampling, and let's get back to the presentation. There we go. So it is a little bit different than the traditional methods. Again, this is timely, it is low cost. So the importance of this is the main costs are volunteer hours to get the information, especially when you're going into the field to conduct the surveys. You need a lot of people to go in the fields because you need teams of 2. So we ended up deciding to do an electronic or telephone-based survey so that we did not have to send people into the field because of the recovery efforts that were still going on. But another thing to note is that the rapid needs assessments are not intended to provide direct services or deliver resources. It is to understand what the community needs at that time. So what we did, again, was an online or telephone-based survey. We did a mail-out in just under a month after the the tornado impacted the community. So on May 24th, we sent out our first mailings. We worked with Douglas County Health Department to figure out what our target area was that we were interested in understanding more about. We decided to do a 2-mile radius around the tornado track, and I think that's on, yeah, right here. So this, you can see the area that we included. So Douglas County had done or worked with other offices in Douglas County to do a damage assessment. And so from that, we obtained some addresses along directly along the path, and then we used tax parcel data to select addresses from the wider area along the tract. Let me go back. And so then we also sent out reminders a few weeks after that because we had a low response rate and we really wanted to get as many people to respond as possible. And this was the first rapid needs assessment that was done in Nebraska post-disaster. And then combined with the Washington County part of the assessment, it was also the earliest to get data collected post-tornado in the U.S. that we could find so far. So we wanted to evaluate the National Weather Service early warning system and the messaging around this event particularly. We wanted to evaluate the local emergency response and communications both right before, during, and after. We wanted to look at mental and physical health impacts of the affected community and then community needs outside of mental and physical health concerns. So we ended up mailing just over 2,500 postcards because we knew we were going to have a low response rate. Mailings tend to not have a high response rate, so we oversampled. Our goal was to get about 168 total responses to get estimates that were, able to adequately and provide reliable information. So we really only needed 168 completed surveys. We did a stratified random sample, so closer to that tract, and then also that 2-mile radius. And again, I've already covered where we got the information from. So we wanted 168 completed surveys. We know from other types of these surveys that we need at least 80% of those to get valid and unbiased results. And we got that with this. We ended up getting 150 completed surveys, which is 89% of what we had hoped to get. You can see we did have overall a low response rate. It was not surprising because there was no incentives for people to participate in this. This was just trying to gather information from people affected. And we know that incentives to complete surveys like this help. And also, there was a lot of other needs going on, so people might not have been as motivated to complete these as they normally would have been. So just to go into some of the results of the survey, so the household characteristics, average size, 2.8 people, 99% of respondents spoke English language in the home. Also, I want to note that because these are population estimates, we provide not only a percent of the respondents, but also these numbers in parentheses are going to be the number of households that we're estimating had these characteristics. Standalone structures accounted for 96% of our respondents. Almost 70% saw or heard the tornado that day. 85% sheltered in their basement, and 93% of respondents knew the difference between a tornado watch and warning. I mean, this is Nebraska. People have experience with these, so that is all good findings right there. However, there are some things here that I want to note. So most people know where it's safe to shelter in their home if they're supposed to shelter in place. Most people know how to receive these alerts and warnings. And most people know how to contact their family members when a disaster happens. However, as we saw after this event, a lot of people did not have the records that they need, like insurance records, immediately available because their houses were destroyed. So we also asked about if they knew how to get copies of those important documents in the event of such a disaster. That's a much lower percentage, 41% said that. And then also, if in a different type of disaster where residents are are told to evacuate, only 30% said that they knew or had thought through how to exit their community in the event of an evacuation. And then the other very important finding, I think, is that only 15% of households reported having an emergency supply kit prior to the tornado. And so these are things that you have available that include batteries and flashlights and a weather radio so that if your power goes out, you can get the information that you need. First aid kits. We usually recommend that these emergency supply kits have a few days supply of medication, have a little bit of food and water available so that you lose power, you have to leave your home, you can take the supply kit with you and you can have access to some important items. Very few had access to these prior to the tornado. And those that did have the emergency kits, only 34% said they had to use them. The most common items were batteries and then food and water. So then we wanted to know about how people preferred to get emergency messaging. By and large, people, if they had to pick top 3 preferred sources, TV, automated text or phone notification, and siren. I do want to point out that social media is the bottom on the list, so 8%, but we'll see why that's important in just a second. So then we asked a question, how did you and members of your household learn about the tornado warning? So siren was the most common. So this was, they could select all options that were relevant: text message, cell phone, TV. Word of mouth was also really important that day. And actually we found in Washington County that word of mouth was even more important than in Douglas County. Social media, again, very low on the list, but for the post-recovery sources of information, social media became more important. We also found that an estimated 108 households in Douglas County in the affected area had a complex medical need like insulin resistance. Some had difficulty accessing their regular healthcare services after the tornado. Some used mobility assistant device or oxygen reliance, and those are all things that can impact whether someone can evacuate or someone can maintain their usual healthcare needs after an event when you lose power. We also noted that there were a number of households in the area that had members with barriers to effective communication, like impaired hearing or developmental or cognitive disabilities. So the good news is that the information about a variety of our recovery resources that were available in Douglas County, most people did know about them. So, 75% reported knowing about the Red Cross and the shelters that were available. 65% knew about the tree limb debris drop-off locations and the reporting hotline. Much fewer knew about the landfill fee waivers that were being offered in some cases, the reunification center, and the tetanus vaccine clinics, which we know that making sure that people are vaccinated and not exposing themselves during cleanup activities is important. And then here's what I'm talking about. After an event, when people don't have electricity or they are very busy with cleanup activities, the methods of receiving information change a little bit. So TV was important, but internet and online news, word of mouth, and social media were the highest in the post-tornado resource phase or recovery phase. So only about 4% of households reported that theirs were destroyed or uninhabitable. 6% said significant, but they could still live in it. 17% reported damage, but repairable. So there was a decent number of households that had a large amount of damage from this particular tornado. But most of them said they felt their house was structurally safe, and only 55 households reported being completely displaced from their primary residence. Most of them ended up staying with family or friends. Very few went to the shelters, and those ended up closing pretty quickly. Over half reported loss of power and access to information. There were no injuries that were reported from the tornado, and very few reported injuries from their cleanup activities. But 19% reported that they had household members that were not up to date on their tetanus shots. So that is something that, getting word out in multiple ways for the tetanus clinics could have been useful to those households. A number reported worsening conditions like allergies or worsening conditions related to their previous mental health diagnoses. Some reported new conditions like trouble sleeping, difficulty concentrating, and agitated behavior since the tornado outbreak. For the households that had children in them, so under 19 years of age, most still reported that they had similar health status prior to the tornado or post-tornado as they did prior to the tornado. And most reported that they were generally in excellent or very good health. However, 17% of these households, so an estimated 144 households with children, reported their children were feeling nervous or anxious or afraid after the tornado. Some were having problems sleeping, and some were worried for physical safety and their well-being. We also, at the end of the survey, asked for individual questions. So 2 of them were related to depression, and 2 of them were related to anxiety. So you can see here that a fairly decent size reported mild, moderate to severe symptoms of depression or anxiety. So 19% to 21% mild, moderate, or severe depression, and in a higher percentage, 24 to 31% for anxiety. So if we look at the last community health needs assessment in Douglas County and compare these statistics with what was found there in Western Douglas County, at the time, moderate to severe anxiety and depression were reported in 8.5%. Here we had 8.3% with moderate to severe. I would like to point out that the last community health needs assessment was done in 2021, so we were still in the middle of the pandemic. Most likely vaccines had not been widely rolled out by the time this survey was done for the health assessment, so we know that a lot of people experienced depression and anxiety at larger levels during the pandemic. So I also compared it to statistics from the US prior to the pandemic to see how this compared. And recent depression or anxiety in the US in 2019, the prevalence was 18.5, and you can see here we are a little bit above that, about 20% with recent depression. And then for anxiety, the prevalence was 15%, and we are much higher. So anxiety was a big factor after the tornado. People were experiencing moderate to severe or mild to severe anxiety, closer to almost 30% for some of these measurements here. So then we also offered an opportunity for the residents to provide open-ended responses, and so this is just a word cloud of some of the most common words in these open-ended responses. The majority were pleased with the response that the county and the state and the federal government did after the tornadoes. There were other comments related to relocation and recovery efforts. There were some complaints. A lot of them had to do with insurance and FEMA, not understanding the FEMA processes, having difficulties getting their insurance adjusters to help them out with that. There were some reports about mental health and other things. Here are some of the comments in their own words that we collected. Many were positive. They felt like there was an amazing response. They were very thankful for the warnings, the sirens that they had heard that day. But there were some frustrations. They felt that they weren't getting the help from their insurance company and FEMA. It was very challenging to get the resources that they needed and confusing. But they also wished that the National Guard had come in a little sooner to help keep unnecessary people out of their communities, because they had a lot of that coming through in the immediate aftermath. So finally, our recommendations. So emergency preparedness kits. Again, only 15% of households had them. So one thing that we can do is to work with community members, work with community organizations to educate people on how to build their own emergency kits, because these are important, because they help individuals and families to stay where they are and to access what they need in emergency situations. So that is one recommendation. We also want to talk about communications. We're actually meeting with the National Weather Service next week to share some of the findings with them related to communications that they were involved with, and also to get their take on some things that worked and didn't. But really what we need to do is ensure that we have identifiable and clear guidance on certain things in a recovery setting. People forget what they knew before. They don't think about things applying the same way. So, for example, what funds and resources are available, how they can be used, potential for non-governmental resources, emergency protocols can be amended to control inflows immediately after a disaster, with people bringing things that aren't needed or not being delivered in the right location. And also we noted, I'm not sure if this is on, so another thing we noted is that when people were doing their own cleanup, especially in the more rural parts of this tract, they started burning. And we were still in drought conditions then. So, reiterating when it's safe to burn, how to get the burn permit, how to do it safely, those types of things are needed in the post-tornado setting or post-disaster setting because people forget what they already knew. Sirens and early warnings. So again, the takeaway from this is redundancy. Multiple forms of communication are important. We did hear from a number of people that they didn't hear the siren until it was basically on top of them. Also, I think I've heard anecdotal evidence, and I have not followed up on this, but there was apparently an outage of a cell phone tower earlier that afternoon that caused some delays in people getting their emergency alerts on their phone. So redundancy is key. Having multiple forms of communication, encouraging people to get those weather radios. I have since gotten one and it goes off and it's so loud and you cannot ignore it. So it's very important to have these multiple forms, robust, redundant systems. And then finally, mental health. So we do know that there is increased anxiety and depressive symptoms and even post-traumatic stress disorder after disasters like this. And so these can both be new conditions, but they can also exacerbate existing conditions. So what we need to do is to, provide on-site mental health counseling and behavioral services in the near term. So have those services available at the shelters, at the reunification center, at the other events that are, there to get other resources to the community. But we also need to consider long-term assistance because there are chronic impacts. The people that have lost everything and are having to rebuild, they are experiencing these in a chronic situation. Like have ongoing stress and anxiety. So helping them to get the assistance that they need to, improve their mental health in the long run is also important. That's it. So I'm happy to take any questions.
I just say thank you for the presentation there. I think that's very important and insightful information that you were able to assess post-disaster. And I guess my question is, do we have plans to share this with Douglas County Emergency Management or council members or county commissioners? I think that'd be a worthwhile thing.
It's a great question and definitely open to that. I was going to make that offer following the presentation that if you wanted us to come to either a county commissioners meeting or city council meeting, we do plan on sharing the information with the DCEMA, but wanted to bring it to the board before we went any further with it.
Yeah.
But yeah, definitely would love to get in front of any of those boards.
Yeah, I'll work with you on that. I think that'd be an important thing to do.
And we also have plans to release this report on your website, and we are planning to do sort of a video type thing to have another way to get this information out.
So, yep, we're going to work with Dr. Christina and put together a YouTube video to put on our website. We have the one-pager, so we were going to continue to push some of this information out, but again, would like to get in front of both the county commissioners and the city council, maybe prior to doing that, so that we can kind of share these results.
Yeah, great.
Yeah.
Well, you all will send this presentation to the board here?
Oh,
yeah.
Okay. Justin, let me know what your conversation goes with emergency management, because I think I need to talk, because they just did a presentation to a committee of the board about this. So you all better talk and get on the same page, and then let me know how that conversation goes.
Okay.
Okay. Because they did something from their view, and talked a little bit about some things. So
Sorry, did they present on an after-action report, or what was it?
they didn't talk about after-action report. They talked about a different phase of what was. They presented basically on the response, some other things that were going on to some degree. It wasn't an after-action report.
Okay,
But it's got some of the same rhyming.
gotcha.
So,
So-
it's something they presented. So I just want to make sure you all kind of coordinate that on the same
Sure.
page.
And just so you know, Commissioner Rogers, the DCEMA was aware that we were conducting the CASPER, and that we had.
Oh, no. I'm not talking about that.
Yeah.
But I'm like, to report it to the board, just have the conversation.
For sure.
Because they reported in a committee meeting, not to the board.
Gotcha.
Yeah,
Okay.
so have that conversation, let me know.
Yep, and we can talk more.
Okay.
That'd be great. Thank you.
Can I ask you all, is the National Weather Service have an office in each state, or is that regional? I feel like I should know that.
In what?
Do they have an office in each state, or
Yes.
do they have regional
They
offices?
have multiple offices in Nebraska and multiple
Really?
offices in most states, yes.
So is theirs here? Is it out on like 108th
There-
and L somewhere?
Omaha and Hastings is the area that's covered by this particular National Weather Service
Uh-huh.
office, and they are out,
They're
Valley,
in
yes,
Valley.
thank you.
Okay, okay. What, it's the State Emergency Management Offices around 108 somewhere. I thought that was it, but never, but there's a like actual presence that y'all gonna meet with to kind of tie that
Yes.
up. Okay. Have they, I was at a meeting, have they stressed with you all their concerns just at the national level with what they're having staff, and is that reflected locally?
We will be asking questions like that next week, I think, when we meet with them.
Okay.
I know that we'll end up having some in-person and some virtual because of staffing issues.
Okay, so yes, there are some staffing issues. So yeah, we'll be doing a focus group next week, and some will be participating virtually and some in person, simply because of the way things are structured at their offices and staffing concerns.
Yeah, I'd be interested to hear what they're saying it is locally to try to help remedy that, because the way it sounded at this meeting, there was some real bad chain reactions in regards to that staff, and that could happen in the future. I mean, they basically said they're losing a lot of tenured, seasoned people that's dealt with this, and having to bring some people back in with the gravity of catastrophe increasing, so like it was a little concern.
And unfortunately, I think that the same thing is happening with public health practitioners and emergency managers around the country as well.
Interesting.
That are the same with National Weather Service.
Okay. All right. I think that's it. This is
Got a
great.
follow-up question?
Oh, sorry.
Yeah. No, thanks for the presentation, really helpful information. I think just being in healthcare, like we were getting a lot of calls about oxygen and like what people are supposed to do. So like I think it would be helpful to make this information more readily available, maybe on the website, because it is hard to know what to do in those settings, and then like what should be in the emergency supply kit, like you were mentioning.
Okay, absolutely.
Great. Thank you.
Thank you.
So, Doctor, you're with UNMC.
Yes.
Okay, and what division are you with at UNMC?
So I am with the Water, Climate, and Health Program
Water,
in the
climate.
College of Public Health.
Okay, all right.
Mhm.
Thanks. All righty. Item C, workforce.
Yep.
Perfect. Good morning.
Morning.
I understand you have a hard stop at 9:30, so we'll move kind of quickly through things. But if you have questions, please let me know. So I'm Jennifer Morgan, the Workforce Development Director here at DCHD. And I spoke with you probably back in April and shared with you a little bit about what the goals were for workforce development. I want to advance the people first culture, systems of growth, which is training and development primarily, and then enhance the organizational stability, which is really the way that we policies and are functioning. And the purpose of this slide is to share with you kind of how this is aligning with the V2R, the vision to reality, our values that we've been working on. So it lines up really nicely that people first and belonging really slide right into that people first culture. Innovative excellence fits hand in hand with training and development and systems of growth. And integrity of how we're doing things is also right in that organizational sustainability. Sliding into V2R and strategic planning. So we've done a lot of conversations within the department, and I know it's been shared with you several times about the work that the teams are doing on understanding what our values are, how it impacts their daily work. And last week, Dr. Hughes introduced and launched the strategic plan to the teams. And really what this is moving those values into what we're doing. So as we're thinking about it and explaining it to all of our teams, the values are how we do things, and the strategic plan is what things we're doing, and really diving into kind of further what we want to be practicing out of those values. Another thing that launched in September was the PHWINS survey. PHWINS is a national public health engagement, satisfaction, training survey done by the de Beaumont Foundation. And we did participate, DCHD participated in the last one that they had, which was 2021. And it launched to all of our employees in September. Working through this, we will have a we'll get national as well as agency-specific results if we hit an 80% response rate. And those results will be made available to us in the summer of 2025. And in this, we're going to be able to understand a deeper level of what our employees are feeling from an engagement, what their training needs are, and a real understanding of kind of how they're thinking. And it'll be very good to be able to look at where we were in 2021 and how far we've come here, and it'll be in 2025. So. There's a lot going on in this slide, and it's really looking at the retention rates. So it was mentioned that, you know, the National Weather Service and others are experiencing a lot of turnover. In looking at the data from DCHD, we actually are doing really well in retaining our employees. In fact, when I deep dove the data, our average tenure is right around 9.5, almost 10 years across the whole organization, which is excellent. And so the retention rates really look at how employees feel satisfaction over time, and it also underscores the stability of our teams and how many folks we've got staying here. And I think that this chart really shows the impact that happened post-COVID. So you can see the 2021 and the 2022, and we all know what was going on there. And then the last 2 years, particularly, and how we've been ramping back up over those retention rates and hitting a 98%. When we look nationally, the comparison is there's not necessarily an apples to apples comparison in the public health sector, but I was able to find in the U.S. Bureau of Statistics, Labor and Statistics, that the retention rate averages for community health workers across the nation is 89%, and with epidemiologists, it's 94%. So in both of those cases, DCHD is doing better than what we're seeing across the nation. The next thing I want to share with you is we are in the process of launching our learning library. And in this, we've gathered over 110 hours worth of training modules for our employees. We're going to have required training, continued professional development. We also have onboarding training, leadership development, and then working on some section-specific training. We'll work with the sections to really develop that out. This program is going to be all self-paced online training courses from a variety of different sources. There's actually a really great database where we can work through with all of our public health partners across the nation to utilize training that's been developed. And so we're going to be sharing that with our DCHD employees so they can continue their education and continue their growth. All of the work that they do will be captured in the Google Classroom that we're using as our learning management system. It's going to track the completion of courses and track the hours that individuals and us as a group have been doing our training and our learning. When we take a step deeper in the learning library, I really just wanted to share that all of the training that we've assessed, all 110 hours that we've assessed, fits into very nicely the core public health competencies. And those are listed out: data analytics, communication skills, all of the things that we've kind of come to think really are important in public health. And so we've got a wide variety that hit that. We also, when I took a look at all of those training courses, evaluated them to see how they reinforce our values. And so we've got a lot of them that hit right into our values. The biggest bulk of them, of course, is that innovative excellence and that continued growth that we're looking for from our employees. One of the other ones that I mentioned was the new hire onboarding. So when I spoke with you last, we had just launched the orientation class. Since that time, we've had 5 in-person new hire orientations, and I think that the feedback on those is really great, that we're getting them lots of good information, making everybody feel welcome, hitting most of those values as we're going through. So the next step in the onboarding is we're going to be expanding that training. So we'll still do the in-person orientation class, but then we'll add in 26 hours of that online self-paced training, which will be captured in the Google Classroom, that they'll be able to do within their first 180 days. And again, that's extending that deep dive into public health, and as well as what it means to us here at DCHD. Our next steps for the onboarding team is going to be to launch our comprehensive new hire checklist and process. So more to come on that, hopefully next time I talk to you. And the last thing that we wanted to hit on today was our policy review committee. So this was another one that we were just launching when I spoke with you last. And we spent these last few months really deep diving into what our purpose and our role was for this committee, what we were looking to accomplish, and what we want to do is review all of our existing body of policies and make recommendations for any changes that are needed as new policies are written, and we'll be able to have another set of eyes from this committee. We've really worked to create a robust and uniform checklist of what makes and what qualifies as a good policy. So the team spent a lot of time brainstorming and working together to develop our policy review questions and checklists, and really define what our process is going to be of who needs to sign off, how we're going to interact with the management staff as well as the senior leadership staff as we're making recommendations on policies and the things that we've identified that we either are doing really well or need to work on. And we also, in all of that, really kind of formulated that role of the committee. The next steps with this is going to be to finish evaluating this questionnaire, get that in front of our leadership, evaluate where we are with our policy template to make sure that everything that's in our questionnaire is also on the template that we're using. And then we're going to start beginning that review process. So that should happen in the next month or so. So that is what I have for you. Are there any questions?
Yes, thank you. So first, I want to, on your policy review checklist questions, thank you for including those equity questions. So nice to see that in practice.
Absolutely.
As far as the courses that you're offering, are there any that are going to be like mandatory to be completed on an annual basis? Yeah, and what are those?
So we actually, the process that we want to establish is we're going to go from a September to end of August school cycle, as it were. And so we'll evaluate the training in that time for us to do for the next year. But we'll have ones such as our confidentiality training, which will be year over year. But we'll still hit the highlights of the core competencies each year, so leadership development, communication. And as we get that PH Wins information back, we'll be able to tailor what courses that we have in that training to what the needs are of the teams. You're welcome.
I'm just your retention number?
Yeah.
I was looking down there. I'm just curious, that 9 years, I just asked because I'm wondering, that's what it is, a cumulative now that's in there.
Right, so that was the average. I looked at 2018 to the end of second quarter 2024, and that was what the average tenure was about 9.5 years.
2018?
2018, yeah.
Okay, interesting. No, because you had some very tenured people on at that time. So.
We did. I think also, and we did pull out most of the time in retention numbers, they do, it is best practice to pull out temporary workers, so we did pull those out. But I do think that dip in 2021 and 2022 post-COVID really knocked down that tenured number that you see.
I'm just curious. So the results of some of this, even this, because this PH Wins survey, I don't recall ever hearing that, and we took it in 2021.
Correct.
Does the result of this go back up the chain to the grantor of this grant as part of the whole grant of what we're doing with this infrastructure? Or is that just for us internally?
Yes. So one of the kind of core components, and Jamin Johnson, sorry, of the Public Health Infrastructure Grant is that we use existing data and resources, especially, and they call out the PH Wins survey, so that across the public health profession, we can show that we're using sort of standardized, some standardized tools. So PH Wins is written pretty heavily into the Public Health Infrastructure Grant as a strong encouragement for us to, one, encourage our workforce to take the survey, but then to encourage us as an agency to make data-informed decisions based off of that survey so that we can then have reasonable comparison data with other local health departments.
Okay.
It's also written into the accreditation that this is useful for the accreditation, so we can use this as an example in our accreditation and hopefully re-accreditation as we go forward.
Okay. All right. Thanks.
Awesome. Appreciate it. Thank you.
You're good. Thank you.
Heather, what about you? Awesome. Thank you.
Right. With that, let's go to item 5 in the Health Director's report.
All right, thank you. And I'm going to stop share here for a second. There we go. Okay. I don't have too much for you today, but I do have some fun updates. So first of all, I know that I've talked to you a little bit about some of the building issues we've had, and that we have a couple of projects that we're hoping to accomplish. And one of those is the renovation of our conference room, our main conference room. Most of you remember being kind of rammed in there for Board of Health for a while. That room is going to be renovated. We are expanding that room and better utilizing some of the space that's available kind of in that upper area of the health department. We're gaining about 165-ish square feet in that room by moving a couple things around and knocking out a wall. We are also updating the technology in that room so that if we really will be able to use that room for anything. We should be able to convene stakeholders in that room a little bit more effectively instead of having to search the community for a room we can use. Our AV will be all set up in a way that hopefully it's more efficient and it's not going down 5 minutes before an EPA presentation, things like that. Hopefully that will be a lot more effective for us. And honestly, if we ever needed to, reschedule Board of Health and couldn't find a room, that room probably is going to work a little better than it did previously for that. So it's going to give us more options. It's going to be, I think, a really, really nice change for our employees as well. So that work is actually starting the 1st of November. So they're going to come in and start moving things around. And I think there's a fair number of people in the health department that would love to be part of demo day and knocking out that wall. So that's coming up. I'll keep you updated as we go with that project. I also wanted to let you know, so the community health needs assessment that we undertake alongside Sarpy-Cass County and Potawatomi County, along with our health systems, has been completed, and we've gotten initial data. It has not been released publicly yet, but they have sat down with the Regional Health Council to present some of that data. We just started getting access to the raw data for that, and so my plan is, first of all, we will, when the data becomes public, I will ensure that the Wellbeing Partners comes in and presents to you on the data that came out of that. However, I'm also taking that raw data and giving that to our health equity epidemiologist and having them do a deep dive into some of that data. And I'd like to present that concurrently with what the Wellbeing Partners does, because I think there's going to be some really interesting insights that come out of that. And I want to ensure that we are, especially given some of the disparities that came out pretty clearly in the initial data, I really would like to do that deep dive so that when we move into priority setting and we're looking at what our community really needs, we're being effective in that choice, and we're not we're looking at as in-depth data as we possibly can when we're making those decisions. So that's my plan with that. So more to come. It's also kind of a timely thing that is come out now as we are just starting up our strategic plan. I think we're going to have kind of a nice concurrence after the first of the year where we'll have basically, community health needs assessment data. We'll have our strategic plan, that's able to use some of that information, and then our annual report that comes to you a couple months into the year. So it's nice that everything's going to be kind of in a nice little bow this year, where that doesn't always happen. I know it's a bit long to wait for the PHWin survey to come forward because we don't get that data until summertime, but eventually I would really love it if all of our assessment data can kind of be put together as we're making decisions about what we need to do and where we need to go. So more to come on all of that. And then probably the most exciting bit of news that I have for you is that our accreditation site visit will be happening in January. We're still nailing down dates. There will be some opportunities for you. In fact, they want to talk to at least a couple of board members. So you'll be seeing some invitations coming out to hopefully get a couple of, of you to provide some information to those site visitors. And actually, I believe one of the dates that they're looking at is January 15th, which happens to be a Board of Health day. And so if there's any interest on this board to hear from those individuals, I'm trying to make arrangements for that, but the listening session or the conversations that they will have with those couple of board members that participate will be separate from that board meeting. So just wanted to prepare you and let you know that's coming. We're super excited because we've been waiting for this for like 18 years. And we're going to get there. It's going to be so exciting. Cannot wait for that. And also on the strategic plan, as we did launch that last month, we will also be bringing you in. There are workshop dates that are specifically including Board of Health so that we can ensure that you are part of our strategic planning process. We definitely need your voice on that. So you'll see those dates coming forward here just in the next few days. And I believe that's all I have for updates. Do you guys have any questions today?
Going back to the community health needs assessment and your epidemiologist, are they going to be willing to look at also the pediatric data? And how, if so, can we coordinate that?
I would love that. We don't have access to that raw data because it's pretty much handled all through children's. I would absolutely love the opportunity to look at that, especially so that we can break down where we're seeing those disparities and things. So I'm very happy to coordinate to work on that.
That'd be great. Thank you.
Thank you.
So, Dr. Hughes, so the last time we presented this over another building, I talked to you a little bit about the control of the community health needs assessment at the time. It seemed like the well-being partners had a little more control than I was comfortable with.
Yeah.
So are you all?
That is a conversation that actually my team and I have been having quite a bit, especially after kind of this most recent iteration. We did have the opportunity to look at all the survey questions and you know, we were able to basically cut things that we felt needed to be cut. We could include things that needed to be included, things like that. But I do still, even 3 years in, have a little bit of a, yes.
Well, I know last time it happened, and it was happening in the mix of COVID. And the department was overwhelmed.
Right.
And that was understandable.
Yeah.
The feel I got is it was feeling like it was theirs and not the health department.
I think it's a little bit better this time around in terms of that. We've had the 3 health departments that are involved in that regional health council, I feel like had a little bit more say in what was going. There were a lot of questions that we were asking of wellbeing partners. And so I really do feel like they were more a facilitator than an owner this time around, if you will. I will say that there are likely some changes to the Regional Health Council coming forward that will be more inclusive, I guess, of our health systems. And so I've been pretty clear with that entire group that, you know, as public health, I'll probably be asking a lot of hard questions and probably being pretty loud in that room just to ensure that we are ensuring that this tool is exactly what we need it to be for public health. And then from a Douglas County Health Department side, we want to make sure that, you know, yes, there's a regional assessment. We know what a priority, you know, what our priorities might be from a regional standpoint, but we really want to look at that data for Douglas County specifically and have our own plan in place and our own kind of assessment. And that's one of the reasons that I've asked our I'm asking our health equity epidemiologist to do that deep dive into the raw data. So we're not just looking at that regional data. We're really and truly looking at what's important here in Douglas County.
Well, if you need a backup on that, I can't speak for the whole board, but I would definitely use in that room that you have a board member that definitely has some concern about that.
Yeah, I appreciate that.
Okay. And when you get to that point, I'd like to, this may be an administrative committee deal because I'd like to do some type of rollout on that.
Great.
Meaning you do the initial hit, but I'm almost thinking, because the way this data's sounding, we needed to set a narrative and frame a lot of other stuff. And I'm not, like the president takes the State of the Union out around the country, I'm almost thinking you need to take it to different parts of the county and frame it up. And
Already planning that.
Okay, all right. And the right players need to be involved with that. Okay.
Absolutely.
Okay.
All right.
Anybody else? All right, we're good.
I think the last thing is the V2R, which is why I'm still standing here. So every month I get to talk to you about a new value and what that means to us. So this month we are rolling out innovative excellence as one of our chosen core values that we've all agreed on as a way that we want to show up for our community. And as a refresher, The two that I've talked about before were being people-centered, and then, or people first, and then belonging. And so kind of shifting a little bit into innovative excellence, this is a really exciting core value for us because, first of all, public health has an incredible base of science, and sometimes that gets lost in the human component. And so it's kind of exciting to me that we get to talk a little bit about being very data-centered, and that we are looking at practices that are working really, really well for other people, and ensuring that we are also following practices that are working really, really well for communities like ours. And so, you know, ensuring that we are not only incorporating best practices into the work that we do, but that we're actually developing some of those best practices. So we want to be part of helping public health in general elevate and be more effective for communities. Part of that is that, you know, we are maybe taking a few risks here and there. We're having ideas, we're being brave enough to innovate and put those ideas into place, and then we're communicating about our outcomes with those particular actions that we're trying to undertake. Probably the scariest component of innovative excellence for me personally is the failure component, because as you are innovating, you are creating something that works great. You're never going to get it right the first time. And so you have to allow and empower some being okay with failure at a certain level. So you've got to empower people to have an idea, try it out, and have it not go exactly the way that you hoped for. And the big thing from that is that you're learning from it. You're taking your result, you're looking at, okay, well, what didn't work? And then you're tweaking it. And then you're trying it again to see if your adjustments are going to make a difference, which, by the way, is performance improvement or quality improvement, which is also something we're working really hard on in the department right now. And so it's really exciting to just be kind of standing in a place where we can empower our leaders in our organization to empower their staff to, hey, you know, if you're the ones who are working face to face with a population or with a program or a community, and you know, like you probably have a hunch what might help in a situation, we need to be able to empower them to actually develop a plan and put that idea into action and see how it turns out. And so innovative excellence to me is really, really exciting, just because there's so much potential, there's so much opportunity there. And it also really is where we can give our staff the opportunity to shine as leaders themselves. And so I'm really looking forward to the conversations we're going to be having over the next month about innovative excellence. And I'm also just looking forward to having how that as a core value is going to change our organization for the better and really make us one of the best. So I wanted to make sure that all of you knew what we were doing this month around the vision to reality. And like Jennifer showed in her first couple of slides for that workforce development update, you know, these values are tying right into that strategic plan, tying right into accreditation. And so I think that we've got some really, really exciting things ahead in the department. And that's all for that. Yeah. I do have one other thing. I am so sorry. We do have a couple of, I meant to bring up with my update, we do have a couple of communicable disease things going on in the community that I just want to put on your radar. So I've asked Justin if he would come up and just give you a really quick briefing on that if nobody has any questions on the V2R. All right.
But let me ask this now. So I probably should have asked on this workforce deal, but how much of the work you're doing with this workforce deal can be projected out? And I ask that because particularly for this particular legislative session, I need to know what are you all doing workforce-wise, your projection out with it in regards to, let's say, you talk about the workforce shortage, the demand. I'm assuming the demand is going to require higher salary, higher degree. I need you all to project out for that something so that I have a narrative and some numbers to have this discussion during the legislative session, because if they do give the locals the 3 point, if they do take the locals up to 3%, that still will be close, but this acts for public health is probably going to be carved out, but I'm gonna need something strong to make it, and I don't know if other departments around the state gonna be able to make it, and it's pretty much gonna be us, and to the point where even if you have to carve out, metropolitan class, I need that type of stuff from you all on the workforce and the stuff you're talking about projected out to make this acts.
I actually am working on a project right now around some workforce. Yes, I have something actually that I'm working on right now that I think will work really well for that. So if you'd like, I can share that with you. And
yeah, I need pretty much the 2 presentations that were there. I need that kind of jointly put into a narrative, because if you take into effect the catastrophe demand, the tornadoes, all that other stuff that comes with it, yeah, they got some opt-out for emergencies, but if you plan for it when an emergency hits, you're behind the scale, because you can only tap the emergency money, it seems like, from the language. If you have that incident that you had at the Maple Wild at Westview,
yeah,
you tap into it then, but there's a whole lot of other work that goes before that, and a whole lot of other planning to be ready for, and I need those narratives to kind of come together to make this case for the exemption.
you got it.
Okay.
All right.
Thanks.
Justin?
Okay, I will be quick, but there are a few things I wanted to update you on. One is there's a lot of attention both locally, nationally, and even internationally about their uprise or uptick in pertussis cases. So far in Douglas County, we've had 18 cases, which is not back to pre-pandemic levels, but it's headed in that direction. And keep in mind, most of those cases were reported since July, and we continue to receive cases almost daily. So just so you know, on average, we see about 40 cases a year, and that was pre-pandemic level. Since 2019, we really haven't seen any pertussis at all. The epidemiology pertussis has evolved a little bit. It's now affecting more adolescents and adults. When you think pertussis, you often think infants, right? But they are still at highest risk of complications and even death. But we know that adolescents and adults, their vaccine coverage is really suboptimal. You actually saw in the presentation of the CASPR, 20% of our population is not up to date on tetanus, which also contains that pertussis component, right? Another thing I wanted to update you on, I don't have a ton of information on this, but there are 14 cases of E. coli that have been reported recently in the Omaha Metro and Sarpy County area. We're unable at this time to make any solid conclusions about where the source might be. We are waiting on some whole genome sequencing, so it's where we actually sequence the entire genetic the genome of these bugs so that we can tie them to each other and see if all 14 cases are related. Of the ones that have been sequenced so far, they're similar to cases that we're finding in Colorado, Montana, Utah, and Wyoming. And so we might be dealing with more of a multi-state or even potentially a national outbreak of E. coli. And lastly, I wanted to give you an update on something that's occurring globally. Rwanda is experiencing its largest outbreak ever of Marburg virus, which is a viral hemorrhagic, much like Ebola. And so you can imagine that our department is already in conversation with the University of Nebraska Medical Center and Nebraska Medicine because of the potential for a global response happening here in Omaha, right? So far there have been 62 confirmed cases.
Hey, Justin, go back, spell this and spell this again.
Marburg?
Yeah.
Yeah, it's M-A-R-B-U-R-G virus. It's again, viral hemorrhagic, similar to Ebola.
And what's the country again?
Rwanda in East Africa, mostly in their capital city. It's a little bit different than the Ebola outbreak in 2014-15, Rwanda and where these cases are primarily occurring, it's a very urban setting, and it seems that they have more resources than what we saw in 2014-15. But we still have 62 cases. Currently, there have been 15 deaths. A lot of those have been in healthcare workers or healthcare providers. There are 21 patients currently in isolation and treatment, but there are recoveries that are occurring. There have been 700 vaccines that have been given out, but these vaccines are not approved for Marburg, so they're being used under an emergency use authorization. And they seem to be doing more testing than what we saw in the 2014-15 outbreak. They have 3,000 tests that they've done so far. But we've already stood up, we had a pre-incident management team meeting in addition to communication with both DHHS and CDC and University of Nebraska Medical Center and Nebraska Medicine. So those are the three things I kind of wanted to update you on in case you start seeing things in the news. Obviously, if anything happens with Marburg, we'll be in communication. Dr. Hughes will reach out to you all.
So explain to me I'm assuming the heart of the response is to try to snuff it and contain it there. Mm-hmm. But what happens in regards to travel alerts? What's that? Oh.
Yeah. So starting today, the CDC is routing travelers from Rwanda to 3 airports and will be doing risk assessments prior to their departure from Rwanda and upon their arrival here in the United States. Those individuals then will be reported to state and local public health, and much like Ebola, we'll determine their level of risk and whether or not they need any sort of active monitoring. And so we've already stood up our REDCap systems that will email and also text individuals that we have to be monitoring. The concern with the University of Nebraska Medical Center is the National Quarantine Unit, obviously, and the Biocontainment Unit, along with Emory, Nebraska, is in the top 2 locations in the country that we would repatriate any Americans that may be assisting in the response that had an exposure or has been diagnosed with Marburg.
Okay, so I need you to do another thing then. You know, this discussion that we had, it was where I'm talking about more about, we had it when UNMC got designated the next project about, you know, I need y'all to flesh that out too and give me something to be ready for I ask about this thing of, okay, so Emory is one, we're one, and to have this discussion about the Fed of if you're going to support that, you got to support the local infrastructure. I need that to really be flushed out now, if that's the case.
Okay.
Because it just sounds like it's,
yep.
If you can hang your hat on UNMC, we need to ride that coattail and try to get some extra stuff.
Yep. Yep. We have been talking about both communicating with UNMC, their governmental affairs person, and also working with the state health department director, and having some conversations with CDC about how they fund local health departments that have regional treatment centers in their jurisdiction.
Yeah, and I want to have it in pocket because this is, you know, if this election ends up being as close as it is, and the one vote comes out of Omaha that makes the decision, then we got to ask to make.
Yep.
And I want to make that ask.
No, I would definitely love to work with you on that. So anything you need, be happy to get that to you.
Work on it. I need it ready.
Okay.
So when the window opens, so make it and get it ready. Okay.
Got it.
All right.
We'll get that done. Yeah.
Any other questions?
Yeah,
Sorry.
I just, I've had the chance to look at the pediatric community health needs assessment data, and everything that you just are sharing is bringing to mind. And I'll make sure you guys see the raw data, but there was a significant drop in parents reporting their willingness to have their kids vaccinated from 21 to now. I mean, I don't want to misstate what the drop was exactly. I don't remember off the top of my head, but I just want to, there was a significant drop. So just all of this happening, I think we just really need to stay on top of it and really start having some conversations around how we do education around vaccines, because parents it's just not happening with their kids as often.
Yep, I think there's a lot of data out there to support that post-COVID. A lot of mistrust in vaccine and healthcare in general. So we're definitely seeing that. And the thing about the pertussis vaccine is it wanes over time. And so it's a lifelong commitment for adults, adolescents and adults, to make sure that they're getting their booster vaccines. Yep. Thank you.
One other question for you, Justin.
Yeah,
so
absolutely.
on the E. coli, so the 14 cases, what kind of time span was that reported in?
Just recently.
Like,
let me see here. It was between October 7th and October 9th is when we received the majority of those cases. So a very short time frame. A lot of times if we don't see ongoing cases coming in, it might have been like a point source where something happened and a lot of people got sick and not something that is ongoing in the community. So we're still waiting to kind of see how this plays out.
and then the genome testing that you were talking about, so that will determine whether it's connected to the other states' potential outbreaks as well, and then maybe make it easier to try and figure out where the source might have been?
Correct. So that genetic testing helps us identify whether or not all 14 of those people are related and have the same bug per se, right? But also will allow us to relate those cases to those other states if they're a close match. Yep. Okay, thanks.
For anybody on reports? Okay. With that, there's nothing came up, so I think we can cancel that administrative meeting for November, and see you all at the next meeting. Thank you. There a motion to adjourn?
So
Well,
moved.
let's just say we adjourn by unanimous consent, because technically we have four, so, yeah.
Okay,
All right, we adjourn.
all right.